Good morning and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stine. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of Good Samaritan Physician Network. With me as usual, Adam Thacker, who is our Chief Operating Officer of Good Samaritan Hospital. We'll be giving you our weekly update with regards to COVID-19 in our community, starting out with some statistics, and then taking you through a lot of the changes that have happened over the course of the past few weeks. Many exciting things have been happening. So just to start off with, around 2,700 total cases that we've had since the beginning. And then the positivity rate's probably the most important thing we talk about every week, around 11% for the 7-day positivity. And then the unique individuals has come down some, around 27%. But as we were talking about ahead of time, around the holidays, around times when government agencies are not necessarily up and running, there's sometimes some delay in that. But one of the most important things is that we've moved out of the red and into the orange.
Right. Yeah, that's exciting. Now we look at that with a positive outlook, but also a little bit of precaution. The advisement from that utilizing that color coding map for counties is even when you transition out of red to orange, that at least for a 2-week period, there's no change in the higher level of restrictions. So we're staying put with what those restrictions look like from a county standpoint. I've talked to Dr. Stewart about that as we move through kind of this holiday season, wanting to be overly cautious with how we make adjustments based off of that color coding by itself, because there likely is a lag in reporting. Now, what we are seeing, though, is even with that, you mentioned the 2,700 cases, and a lot of times we've talked about the last 30 days. It's the first time I can remember in a number of weeks of us talking that the last 30 days is not greater than 50% of the cases. So it's showing climbing and climbing and climbing. The last 30 days shows about 900 cases, so we're about a third of our total. So that does trend in a positive direction, and certainly a reason for us to look at that as if that's something that we can sustain, that will be a good thing.
Yeah, and we fully anticipate when we've looked at the last several holidays that we've been through, there's usually been a spike a few days out, up to 2 weeks out. But we're cautiously optimistic that people have taken precautions over the holidays. We got one holiday still coming up, and so again, we would ask people to be very cognizant about what their plans are and who they're going to be around, and trying to keep it within that inner circle of your family, so we can reduce that transmission. Now, one of the exciting things that's happened over the course of the past week or so has been vaccinations. And I would say volume-wise, really amazed at how many vaccines that we've been able to administer over the course of the past week or so.
Sure. Vaccine number 1 was given on December 17th, and we are over 1,000 vaccinations have been delivered to date, and we're averaging in the ballpark of 150 per day of our phase 1A coming through, and that's our healthcare eligible and our long-term care staff. So that's really tremendous numbers. Didn't know what to expect. We have capacity around 200, and we've been able to stay pretty full on most days. And I mentioned 1A because certainly one of the communications last week was phase 1B and what that looks like. And so phase 1B is going to be those essential workers outside of healthcare. So think your transit, your food, your education areas, first responders, all included in that. And then our community members age 75 and older. So last week, while we were administering vaccine, we also received a lot of calls. When am I eligible, and what does that look like? And I can tell you that there is a state meeting today with our Indiana Vaccination Advisory Committee to look at that guideline that was released by CDC on phase 1B, how that will be implemented, what it looks like, how much vaccine we have with compared to how much 1A are still left to be vaccinated. So a lot of decisions to be made really at a state level. That's not a local decision-making process. And ideally, next week, we will have some information to share that will say, okay, we have some dates of when this will go live, what it looks like, how you will sign up. Our Good Samaritan COVID vaccine clinic will continue to run for an indefinite period of time as long as there is a need. So that will be something that the community will be able to seek out and get vaccinated through the same process that we're using to vaccinate our employees and other healthcare workers to date. But overall, very exciting, 1,000 plus vaccines, and probably most important, is that we have seen side effects be consistent with every other vaccine, that flu vaccine and vaccines that we talk about, where there's some site pain, soreness, a few hours to 24 hours after, maybe a little bit of feeling tired as your body is kind of mounting that immune response, but we have not seen significant side effects that have led to needing additional care. Certainly no hospitalizations, anything of that sort, which is very, very positive, because obviously there's been some concern about what this will look like from a vaccine standpoint. So the side effects have been pretty negligible, and I think that's consistent with what we've seen nationwide.
And many people had asked, is there going to be enough vaccine? And I think we were both kind of concerned initially what those releases were in terms of quantity were a little concerning. And then actually we've received more vaccine than we anticipated that we would have by this time, which is encouraging.
Yeah, the allocation has been encouraging. I mentioned the 1,000. We've already received 2,500, and we are getting weekly allocations. So we expect to be able to meet a pretty high demand. Now, certainly, Phase 1B is a much larger group than just healthcare. Phase 1C is the 65 to 75, and also anyone 16 to 64 with health conditions. So those become very large populations, and that's when the supply of vaccine versus the demand of those wanting to get vaccinated will get a little more strapped. Certainly, the volume will increase. But with Moderna vaccine getting approval, and we have 2 more vaccines that by the end of January are expected to also get emergency use approval, feel positive about being able to kind of stay ahead of that curve.
Yeah. And the important thing also to add to this is what we've spoken about in the past, which is the monoclonal antibody infusion. And that's really going to bridge the gap, especially in the population that Adam's talking about, which is that 1C population. The population that we worry the most about in terms of comorbid risk factors, cardiovascular disease, diabetes, kidney disease, chronic lung disease, immunosuppressed conditions on medications, cancer patients, all of that population. Really the bridge to getting everybody vaccinated is this monoclonal antibody infusion. And to date, we've given around 140 of those, and it has been very encouraging. One of the important things that we've really kind of changed our message to the public on, though, is get help quickly. If you are an individual in those risk groups, please see a provider, get in contact with your healthcare team to discuss with them what your symptoms are, get tested. We have those rapid tests available that come back within 15 minutes, and then we can make those decisions very early in the disease process to administer that monoclonal antibody infusion. Dr. Mahan and myself have been kind of dealing with administering that over the course of the past several weeks, and it has truly been amazing that in the patients that get that administered early in the disease process, in the first 7 days or so, we have seen some tremendous turnarounds in some people who have been very ill with the virus and have recovered very quickly.
Yeah, a lot of positive results. 1 hospital admission and 140 treatments administered, and that's something that there's starting to be some articles. I actually had a board member send me an article this morning in the I forget exactly which Washington journal, about hospitals that were getting allocation of monoclonal antibody but not administering it, and Indiana has been on the forefront of that, have administered, I believe, the most in any state. And so we've seen those results. Certainly that's the bridge to the vaccine, but as you mentioned, it kind of starts with testing. And we've communicated each week about testing, and at some points we've said, if you don't feel ill enough that you need additional care, don't get tested. But if you are in those high-risk categories, certainly start to feel symptoms, getting tested, there's a window of time that this antibody treatment is appropriate for use. It's within the first 7 days of symptoms. So really that 2 to 5 days is kind of the sweet spot. Get tested, and it does require a positive test for the treatment to be administered. So that's why we're pushing the testing, is that's a requirement from the FDA approval, is you have to have a positive test result. It can't be an assumed, you sound like you have it, we'll order it. There has to be a positive test for things to move forward.
And that testing, that rapid testing that we've been doing for 4 to 6 weeks now, really we've gained a lot of confidence in that. When we started out initially with the PCR send-off test, we were concerned about the rapid test, but the rapid tests really have proven themselves out, especially in that symptomatic population. Initially, that rapid test was being used in sports teams and screening of all kinds of people, and the statistics really didn't look very good to us, and that's one of the reasons we weren't using it very early on. But as the numbers have come through, and we've kind of done our own little internal studies looking at those positivity rates, and they match up very well. And so it's really important to understand the difference between asymptomatic testing. Let's say that you have to have it done before you travel or before you return to work or go to school or something like that, versus our symptomatic population. And that symptomatic population, the rapid test has proven to be very effective. And it's really that key to identifying the disease process early and then getting that monoclonal antibody lined up for those folks. So we've been excited about that. Many people are asking, obviously with the Group 1C pushing off a little farther than what we probably initially anticipated, how we're going to be dealing with that. And really the monoclonal antibody is the answer to that bridge.
Right.
So we are moving from red back to orange. We're a little cautious about that. Tell us a little bit about visitation policies, what's going on with that now, and then what we can anticipate number-wise.
Sure. As we moved into red, one of the changes we made, and we had talked about it kind of anticipating that was going to happen based off where the numbers were running with our visitation policy, is we are restricting visitation in our ambulatory, so medical office spaces, as well as what we call ancillary, so think imaging, lab, physical therapy, outpatient services, outpatient surgery. That's limited to no visitors, except for circumstances where medical decision making is involved, for such as like power of attorney and those types of decisions for a patient to be made. Obviously, pediatrics has a parent or a caregiver with them. On our inpatient side, our visitation remains as one visitor allowed, and that is from 10A to 6P that we're allowing that. Even though we've moved back to orange, we're still not going to relax visitation on those ambulatory or ancillary areas for the reasons that I mentioned. We're still in this cautiously watching that. Certainly it's something that visitation has been a hot topic since March, and we've tried to balance family being a part of the medical care with your loved one as much as the safety of everyone. It's still really at the top of the list right now in how you reduce the transmission of COVID absent having enough people vaccinated is keeping space. And so we have to decrease the traffic in our facilities. I would say that Good Samaritan is, from an infection prevention standpoint, from a safety standpoint, as safe a place in the community that you could go, because we're well equipped to deal with reducing infectious disease transmission. Nonetheless, we want to keep traffic low. We want to make sure everyone's safe and that all of our services can remain open. And that's kind of at the forefront of our decision making, is we want to be able to keep all services open. So how do you do that in the safest manner? And that right now is reducing traffic, reducing visitors. We have text communication with our surgeries. We have MyChart portals where patients' families can still be involved and see the care and see your physician notes and those types of things to be able to follow along with the care where they can't actually be there. If you're having a medical practice visit with a patient and they need somebody to call in and listen and be part of that visit, they still can from a virtual standpoint, just like our virtual visits allow that to happen remotely. But those in-person interactions, as much as we can reduce those right now, it's still what we need to do.
Yeah, and as we've talked about a bit in the past, the virtual environment, although that seems somewhat foreign to us starting the year out, really has proven itself great, especially in terms of the things that you just said. A lot of the post-operative follow-ups that I have been doing with patients have been virtual. They love that. Keeps them out of the office for unnecessary things where they don't necessarily need a critical physical exam to determine what's going on. So that's really been fantastic. The patients seem to appreciate that a lot, and similar to kids getting checked out for minor illnesses as well. As we transition through the next week or so, one of the things that's going to be a topic we'll ultimately talk about again is kids returning to school and kind of where we go with things for that. The majority of the schools in the area are slated to return 4th, 5th, 6th, kind of around that time frame. But it's important to realize that this is a rolling conversation that goes on nearly every few days or so to make sure that things are safe. Generally, in this area of the country, we see our normal flu season to be January, February, March. So most people kind of figure that flu season starts in October, November, December. That's really when we're getting our vaccines ramped up. But January, February, March tends to be that post-holiday, everybody goes inside. We usually don't wear masks and go through all the precautions. So we're hopeful that because of all those precautions that are being taken, that we don't see that much of a flu season this year, and also are reducing our COVID exposure. But it's important for everybody to realize that the schools have done extremely well. We are hopeful that everybody returns back to in-person learning, and if not, there's a lot of things that have been put in place over the course of the past several months to ensure that regardless of what's going on, that the schools will be safe.
Right. I think in the school environment as well as in the employment environment, one thing we've learned in 2020, and it's going to carry forward to 2021, is we have to be flexible with each week, and there may be changes, whether that is students moving from in-person learning to e-learning, whether that's in your own workplace, working from home versus coming into the office. We've just got to be flexible with that, because while we're talking about the vaccine and a lot of positive comments and certainly, even leaders of the country from COVID standpoint, Dr. Fauci, talking about reaching herd immunity, we're still talking about January, February, March as kind of a critical first 3 months of 21 where we won't have reached that. And as you mentioned, flu season in the Midwest will be picking up. We haven't really talked about flu at all this year, but we also haven't hit what our peak season is. And even though we expect the flu season to be less just due to all of the preventions that we have in place for COVID, there will be a flu season of some sort. And that convergence with COVID has always been kind of a concerning point, because onset and presentation can look similar, and the transmission of each of those is a little bit different. We have to just be cognizant of that.
And as we move into those seasons, it's important to realize that we have testing and we have treatments for both disease processes. So it's important to make sure that early in the course of either of those illnesses, we've known for years, because of the way that our flu treatment is, that early diagnosis and early treatment really works well. And the majority of the time, if somebody comes in with true influenza that's positive and they're 4 or 5 days out, there's not a lot of utility in treating that. So just as we're saying the same thing to be true with COVID-19, early diagnosis, early treatment, same thing is the case when we talk about influenza as well. So just make sure that if you're in any of those risk groups that we talk about, to be in contact with your providers early in any of those disease processes so we can get you tested and determine what treatment would be appropriate. Any other major things before we go to the phones?
The only other thing is a couple of questions that I had over the last couple of days. Certainly the news feeds are somewhat lighting up with the new variant of COVID and in the UK, and there are some countries making decisions on shutting down borders, and certainly it's came out that the U.S. is looking at that. We sitting in Vincent's don't have any input into what our U.S. border decisions are.
Can we shut down the Illinois-Indiana border? Is that possible? Hopefully not.
But with that variant, I think the key in the reading that I've tried to keep up with, the key element on the vaccine is all of the scientists in support of the vaccine have came out and said, because of this technology, the mRNA approach and the way that works, is even with this variant, they've already tested it against the vaccine, and the vaccine is effective. There have been some 19, 20 variants of COVID, so as with all viruses, it does mutate, but the vaccine is effective against all of them thus far. Doesn't mean it always will be, but that's I think really promising that we're seeing that level of protection to a mutated virus, which hopefully means that we'll continue to see that.
Yeah, and as we've talked a little bit about in the past, the breakthrough with using this sort of technology for this vaccine really addresses that very issue, whereas every year we know that there's a new flu vaccine, H1N1, whatever variant that they've determined from Hong Kong and Norway, and then it wraps around the globe 6 months later to come get us. It's important to realize that is looking at the outside of the virus, and if the outside of the virus changes, which that's what they're designed to do, then the vaccine isn't quite as effective. Right. But with the new vaccine technology, really that's something that is ultimately, we believe, going to be the future of what we do with flu vaccine and potential other upper respiratory vaccines. So for everybody that's concerned about the technology, so forth. The technology's been around. It just hasn't been necessarily utilized in this capacity before. So again, we are super encouraged that not only is this going to be a huge breakthrough in ending this pandemic for us, but really looking forward to what the future vaccination is going to look like for our flu vaccine and other respiratory viral type vaccines. Any other things before we move to the phones?
No. Let's see what questions we have.
Presumably people are at home, they're on their couches, they're on vacation. Hot topic day to day.
Okay, so one person asked, can you take the vaccine the same day that you are scheduled for steroid shots for arthritis?
It's a great question. And so in general, when we look at anything that would suppress your immune response, we try to separate those as much as is reasonable. Usually we try to separate that by as much as 4 to 6 weeks or so. However, there's always a little bit of a trade-off to say if, let's say, you have crippling spinal arthritis, and if you don't get your vaccine or don't get your immunization as close as possible to that, separate it out as best you can. But if you have to get it, then that's just something we kind of have to deal with. So my advice to people would be try to time your 2-month, 3-month, 4-month, 6-month steroid shots for your arthritis or for your spine disease, those types of things, as far away as you can separate it from your flu vaccine and as far away as you can separate it from your COVID vaccine. But if those things have to get closer together, that's just simply one of those risks and benefits that we deal with in medicine every day.
I know there's no exact date for phase 1C, but is there any indication of a time frame of when that might be?
We haven't gotten any exact dates or even hey, we're kind of looking at, end of January, end of February, what it would be. I think, our team internally has talked about it, has looked, and just as things are getting planned out, we look towards 1B, that essential workers and 75 and older being probably mid-January as a rollout for Indiana. Now, every state's going to look a little bit different in what that is because of allocation of resources. And then 1C, probably a month to a month and a half following that, so mid-February to end of February. And again, the key factors that can change that pretty dramatically are available vaccine as well as the number of individuals that are seeking the vaccine, because it's all supply versus demand and how that works. But the goal at the onset of vaccines started to get approved with 1A, 1B, and 1C was to move through those by the end of March. So that tells us that it's got to be somewhere in that framework.
And many people are asking, where is the list and where do I sign up? This is not something that we're keeping secret. This is something that is literally changing week by week by week. So there is no magical list. There is no magical online list. The first round that we are going through now was fairly easy logistically because it was through the professional licensing bureaus. So within Indiana, the way that it was rolled out was any of us that carried professional licenses, they already had our email, they already had our contact information, and it's been rolled out that way. Obviously becomes a little bit more challenging when we look at the essential worker group that you described as to how we look through that data and how we comb through and say, okay, this is our next group that we're going to be looking at. What we're doing in practice is we're looking at our patients and saying, hey, you are in the high-risk group as we've been seeing them over the past several months. So they understand. The age cutoff's easy. We know 75 and older, they know who they are. But the individuals that are in that 75 and younger, 65 and younger, 55 and younger, so forth group, we've been trying to educate that population over the course of the past several months in anticipation of the vaccine to say, hey, you may not realize it, but your age is not your risk factor, but your chronic kidney disease is your risk factor. Your rheumatoid arthritis that you take immunosuppressive medications for is your risk factor. Those types of things are what we've been trying to educate our patients over the course of the past several months. So stay tuned. When we know, you will know, and that's part of the reason that Adam and I do this every week is we get out that information that comes through to us on a daily basis and try to distill it down to the most pertinent things we can give to you.
Another things that will affect that access point also is while Good Samaritan, I mentioned our clinic will continue to run and meet the community need as long as it exists, the health department under Dr. Stewart's leadership has signed up to be a 1B and then forward to 1C provider of COVID vaccine, and then assumably the local pharmacies and some others will as well. So that information is still also to be determined as to where the access points will be, but there will be multiple, and even while we have a vaccine clinic set up right now because of the control of the vaccine, as that becomes more readily available, we'll have vaccine in the medical practices where your primary care provider can provide that vaccine at an office appointment, just like other vaccines.
Is there any information that's new yet about whether this is going to be a one-time vaccine or yearly?
No, that still remains to be seen. So what we know today is it is a 2-shot regimen. So with the Pfizer product that's approved, it's 21 days apart. With the Moderna product that was more recently approved, it's 28 days apart. Now, coming forward, the next 2 vaccines that are kind of slated from a timeline standpoint to get approved, AstraZeneca is also a 2-shot regimen. But then the Johnson & Johnson vaccine that's looking somewhere in early February is 1 shot. But how long immunity lasts, we talked a little bit about the variants, and right now the vaccine shows protection against those, but it's really it's unpredictable to know if there will be variations that it doesn't protect against, and then a new vaccine has to be created, and that's when you start looking at, okay, is this an annual event, and what does that look like? There's really just no way to know that at this point.
And ideally, over the course of the next 6 months and 9 months and beyond, those studies are going to be conducted.
Yeah.
Basically looking at what, like the antibody titer that I will have from getting my vaccine, that's something that they will be studying to look to see if patients continue to have that antibody level, then ultimately they won't need another vaccine. We will learn more and more about how the variants change and how effective the vaccine is, because we'll have much larger populations to look at to see how efficacious that is.
I think that's a key element. So as these vaccines get approved, they're approved under emergency use authorization. I think if you're not familiar with clinical trials, it's probably easy to assume, okay, everything stopped and now it's just in the market. All of these Pfizer, Moderna, AstraZeneca, even as they're approved, these trials and the phases, so phase 3 is the clinical trial where it's getting emergency use, those all still are continuing to be modeled out and evaluated, and they're now using all of that data to answer some of these questions that we just don't know the answer to today.
Yeah, and I get asked nearly on a daily basis, what about the pregnant population? What about the lactating population? What about the pediatric population? All of those things are being studied. Now, we had said in a previous episode that we were talking a little bit about the safety in lactation, and I said, yeah, as far as we know, that's going to be fine. There have been multiple large groups, including our MFM group that we use down in Evansville, that has said absolutely safe in terms of the lactating population. We also are eagerly anticipating what happens. There are going to be people who are pregnant when they get vaccinated that don't know they're pregnant. Those then get recorded to determine safety and efficacy long term. And then the pediatric population, we're not just leaving those folks out. The fact of the matter is we've seen much less severe illness in the young population. In many cases, the kids basically that are in households that have had positive cases, kids don't show any symptoms whatsoever. And so that's the reason that hasn't been really a priority. When we look at those high-risk groups, that's really the people that when they get it have the biggest problems.
Yeah, we've kind of seen the vaccine put into red, yellow, green, and green has been get vaccinated as soon as your time comes. Yellow has been weigh risk benefits and kind of your own health risk. And then red, and really in the red, as far as should not get vaccinated at this time, is if you have known severe anaphylactic reaction to vaccines, and anybody who is acutely ill should not get vaccinated at that time. Wait till later, such as I've gotten the question a couple times, what if I actively contract COVID? Well, until you're considered recovered, there's no sense in getting vaccinated. But once you're recovered, go ahead and get vaccinated. Even if you have natural immunity, there's a consideration to wait until 90 days post testing positive for COVID. But when your time comes up, you can get vaccinated. That's not a requirement.
Someone wants to know if you guys got the vaccine.
Yes.
Yes.
So as soon as the doors opened, I think Adam was there waiting with a shot for me. Uh, the story is, every day I have people that come up to me that say, "Are you going to get this vaccine? Is your family going to get this vaccine?" And before COVID, before anything else, I would have long conversations with people about the safety and efficacy of our vaccinations in our country. And if you look at of all of the medical interventions that have happened throughout all of history, the single greatest thing that has saved more lives in the world has been vaccination programs. And that is undisputable. Unfortunately, there have been all kinds of crazy things with regards to safety of vaccinations, autism, things like that. The best thing that I can tell you is Dr. Wakefield, the person who brought this all up, is in prison in Europe right now as a result of all of that. He was the person that brought all that up and scared everybody to death with regards to vaccines. But if that doesn't convince you, the thing that should be most convincing is I've gotten the vaccine. My family will get the vaccine. I have no concerns with regards to that. So this is something that's not just important for my health, but it's important for the health of all the people that I take care of. And many people have asked, how did they come up with this 1A, 1B, 1C program? And Adam and I have literally been crossing our fingers and hoping that our team of workers, our workforce of doctors and nurses and respiratory therapists and radiology techs and everybody else who has been key in taking care of this population would not come down with this illness until we were able to vaccinate them. And so the day that this started, the reason everybody was so excited was the fact that we knew we would get the vaccine and be able to continue working. Because literally every week that's gone by, we cross our fingers in our office and we hope that somebody that is a key member of our team doesn't go out, because that limits our ability to provide that health care to our population. So that's why this has been such a big deal. Really looking back to those first vaccines that were given and all the postings from the doctors and nurses, everybody getting vaccinated, that's because this population of providers, we really, really don't want to have to go home and not be able to continue providing for our population. So that's why that's so important. That's why the vaccine is key to all of this.
Someone asked if they have not received their notice from IPL Board, should they contact them or just wait a few more weeks?
I was told last week on our state call that a notification would be going out today to all those professional licensing agencies again. I think there were some sent out initially. It seemed like there may have been a few glitches with that. We also sent it out internally within Good Samaritan, but today a second communication from those boards is expected to go out. So if you don't receive something by the end of today, you can either contact our team here and we can help guide you with eligibility, and we have a triage line set up, which has been our COVID triage line since March, also answering vaccination questions. And we now have a COVID vaccine hotline set up that's going to be helping move into that 1B, helping some of our community members to get signed up and how to navigate the scheduling process. So those will be resources that we can get you to the right place.
That's all we have today.
All right.
All right. Thank you very much for joining us. Again, we'll be with you in a week or so with updates. Please be safe as we go over the course of the next week or so, not just as it pertains to the virus, but New Year's is a time where we want to make sure that people are cautious out on the roads with their driving, their traveling habits. So be cautious, and we'll see you in a week.